Hi everyone, I'm Shukrit, and this presentation introduces a two-stage machine learning framework for automated ECG analysis. The work focuses on separating abnormality detection from disease-specific classification in order to address class imbalance, interpretability, and clinical alignment in ECG modeling. Electrocardiograms are a foundational tool used in cardiac diagnosis and are routinely used for both screening and clinical triage. From a machine learning perspective, ECG analysis presents several challenges. Most clinical datasets are heavily dominated by normal recordings, while abnormal cases are relatively rare and highly diverse in their morphological patterns. As a result, single-stage end-to-end classifiers often struggle with class imbalance and tend to overfit dominant normal patterns. In addition, purely predictive models provide limited interpretability, which is a key requirement for clinical adoption. Given these challenges, the core problem addressed in this work is how to design an ECG analysis framework that remains robust to class imbalance while providing clinically meaningful interpretability. In practice, ECG interpretation follows a staged process. Clinicians first assess whether a recording is normal or abnormal before identifying specific pathologies. However, most machine learning models do not reflect this structure. This work therefore examines their three questions. Can normal only modeling reliably detect abnormal ECGs? Does restricting classification to abnormal ECGs enable effective multi-label diagnosis? And can anomaly information support downstream classification? All experiments in this study are conducted using the PTB-XL dataset, a large publicly available clinical ECG corpus. PTB-XL contains 21,799 12-lead ECG recordings collected from over 18,000 patients, with each recording spanning 10 seconds. All ECGs are annotated by cardiologists using standardized diagnostic statements. For evaluation, we use the predefined patient disjoint force provided with the dataset, ensuring that no patient appears in more than one split. This design prevents data leakage and supports reliable and reproducible performance assessment. The PTB-XL dataset provides not only diagnostic label but also confidence-based likelihood score assigned by cardiologists. These scores enable construction of subsets with varying label reliability. In this work, we define a strict normal ECG as one labeled normal with likelihood greater than or equal to 80 and with no other diagnostic label having likelihood above 15. This high confidence subset is used exclusively for training the anomaly detection model. All remaining ECGs are treated as abnormal and are used for supervised disease classification in the second stage. This separation enables clean normal only modeling while preserving pathological diversity for diagnosis. This work proposes a two-stage framework designed to mirror the way clinicians interpret ECGs. In stage 1, a residual convolutional autoencoder is trained solely on strict normal ECGs. At inference time, reconstruction error provides an anomaly score that identifies deviation from the learned normal manifold. Stage 2 is supervised residual CNN classifier trained only on abnormal ECGs, which predicts four major diagnostic superclasses: myocardial infarction, ST abnormalities, hypertrophy, and conduction disturbance. In addition, the reconstruction error map from stage 1 can be used as an auxiliary input channel, allowing the classifier to focus on segment exhibiting the strongest deviation from the normal morphology. Stage 1 performs anomaly detection using a residual convolutional autoencoder trained exclusively on strict normal ECGs. The model learns a compact representation of normal ECG morphology across all 12 leads and timestamps. During inference, each ECG is reconstructed and the difference between the input and the reconstruction is computed. This reconstruction error is aggregated across leads and time to produce a single anomaly score, which quantifies how much a given ECG deviates from the learned normal manifold. ECG with a high reconstruction error are therefore more likely to be abnormal. This slide summarizes the performance of the anomaly detection stage. Reconstruction error distributions show a clear shift between normal and abnormal ECGs, indicating that autoencoders successfully captures the structure of healthy cardiac signals. Quantitatively, the baseline residual autoencoder achieves an area under the ROC curve of approximately 0.79 on the held out test set, outperforming the dilated variant across all operating points. By calibrating the anomaly threshold on the validation set, we obtain a balanced trade-off between sensitivity and specificity, confirming that reconstruction-based scoring provides a reliable signal for abnormality detection. In addition to quantitative performance, the anomaly detection stage provides interpretability through reconstruction error. Normal ECGs are reconstructed with high fidelity and minimal residual error. In contrast, abnormal recordings exhibit localized reconstruction failures. As illustrated here using a hypertrophy example, pronounced morphological deviations such as elevated R wave amplitudes produce concentrated error regions. These error maps highlight waveform segments that deviate most strongly from learned normal structures, providing interpretable evidence of abnormality. Stage 2 performs supervised disease classification using a residual convolutional neural network trained exclusively on abnormal ECGs. The model operates in a multi-label setting and predicts four major diagnostic superclasses: myocardial infarction, ST abnormalities, hypertrophy, and conduction disturbance. In addition to baseline classifier trained from scratch, two variants are evaluated. The first initializes the classifier encoder using weights from the anomaly detection stage, and the second augments the input with the reconstruction error map produced by stage 1. These variants allow us to access how information from the anomaly detection stage impacts diagnostic performance. This slide summarizes disease classification performance for the three stage 2 variants. The vanilla residual CNN achieves strong discrimination across myocardial infarction, ST abnormalities, and conduction disturbance, while hypertrophy remains the most challenging class. Incorporating the stage 1 reconstruction error map as an auxiliary input yields modest but consistent improvements for the diagnostically subtle classes, particularly ST abnormalities and hypertrophy. In contrast, directly transferring the encoder from the anomaly detection stage consistently degrades recall and overall F1, indicating that representations learned from normal-only reconstructions do not transfer effectively to disease discrimination. To contextualize these results, we also evaluate a fully supervised single-stage baseline trained end-to-end on the full PTB Excel dataset. This model achieves the highest peak classification performance consistent with prior large-scale ECG studies. However, the proposed two-stage framework remains competitive while offering explicit abnormality filtering and interpretability through reconstruction error. Unlike single-stage classifier, this two-stage design mirrors clinical reasoning and provides transparent intermediate outputs, making it better suited for triage-oriented and critical healthcare application. In conclusion, this work shows that a two-stage approach to ECG analysis provides a clinically aligned and interpretable alternative to traditional end-to-end models. The first stage enables effective anomaly detection with transparent reconstruction error maps, while the second stage delivers strong multi-label disease classification on abnormal ECGs. While full end-to-end optimization and broad clinical validation remain areas for future work, the proposed frameworks offer a practical balance between diagnostic performance and interpretability, making it well suited for triage-oriented and decision support application in clinical practice. This concludes the presentation. The complete code and report are available at the GitHub repository linked here. Thank you.